Pittsburgh Medical School, did her MD, PhD there, and then trained in arguably the best training program in the United States. She was at UCSF, and then did fellowships in Montreal and Toronto. She's really an accomplished, nationally and internationally known functional and stereotactic neurosurgeon. She's now she's Vice Chair of Research at University of Colorado. She moved to Minnesota. She has NIH funding. She's very well published. And has done a lot for organized neurosurgery. She's currently very active. She's very active in CNS and very active in AANS, running the scientific program for this year's AANS meeting. So we're very fortunate that from a busy schedule, she took time to be with us here today. So without much further ado, Dr. Abasch.
And it's a pleasure to be here. I'll just say that this is my first time to Shreveport. And I've gotten the lay of the land from Osama and his colleagues, and I really appreciate the hospitality that you guys have shown me. So this is supposed to be interactive. This is not the typical talk that I give where I stand up and I talk about research or clinical aspects of functional and stereotactic. This is about how to set yourself up, how to grow a program. This is specifically intended for the residents. And if the PGY1s thinks that they don't have to deal with this, it's amazing how quickly 7 years goes by. So. This is my outline. I'm going to talk about how I have developed, how I've tackled the issue of developing a program in stereotactic and functional neurosurgery, how we measure success, and leave it open for discussions of pitfalls and obstacles. My premise here is that you all want to be successful. You want to have a successful career, whether that's in private practice or in academia, and that you want to take cutting edge and excellent care of patients, and that you all understand that you don't end your training. I didn't end my training when I left residency or fellowship number 1 or fellowship number 2, because the field continues to move, so we all have to continue to move and stay current. That it's important to you to have a sterling reputation, that you want to be the person that people turn to solve a question of complex spine, that you want to be the person that people turn to for an endovascular or an open vascular solution, et cetera. And that to remain challenged and remain fulfilled by your career, you understand that it's dynamic, that the field moves and then that you have to move with it. Whether or not you're going into academia or community-based medicine, although the org charts can change slightly between those two spheres, the underlying truths that I'm talking about today, I believe are the same. And I will say that with the following disclosure, that I've never worked outside of academic medicine. I have been tempted, sorely tempted, to leave academia in frustration at various times. I've looked very carefully at options in private practice systems and have ultimately not been able to pull the pin. So, how to set up a comprehensive program in functional neurosurgery. And by functional and stereotactic neurosurgery, I'm of course referring to epilepsy surgery, movement disorder surgery, pain surgery, spasticity, and peripheral nerve. These all get lumped in. If you were writing a textbook of neurosurgery, volume 1 would be tumors or vascular, volume 2 would be spine or tumors or vascular, volume 3 would be stereotactic and functional. So, what patients am I treating is really the first question you have to answer about how to build your comprehensive program. So how do I define that? Now, there are many ways to define what you do. I mentioned all aspects of stereotactic and functional that exist right now in 2015, although, as I said, the landscape changes from time to time. But I don't have to treat all of those patients. The question is, why should I treat all of those patients? I should treat those patients if I'm passionate about treating them. I should treat them if I have something to offer them. And I should treat them if I don't have to hit my head against the wall to get them into my clinic. When it's too effortful, so for instance, if all the spinal cord stimulator referrals in my environment go to orthopedics and not to neurosurgery, then I either have to address what the barriers are to referring those patients into my clinic, or I have to pick something else to do. Those are the options. So, what patients am I treating? Where do my patients come from? What are the internal referral sources? Because if you can't convince your colleagues within your institution, within your practice, within your community hospital to send you patients, how on earth are you going to convince the region, the competition, get patients from national or international sources? Obviously, this should be intuitively obvious, but it's worth stating. So, starting with what the components of a comprehensive functional neurosurgery program are. So I need to identify in my institution or in the job that I'm considering taking who the adult and pediatric neurology specialists are in my area of expertise. So who are the movement disorder neurologists, who are the epilepsy neurologists, and who are the headache specialists? Number one, I create headache, which needs to be fixed. Number two, I treat chronic headache with certain techniques. And so those are all important referral networks for me within my institution. Psychiatry, very important. OCD obviously is FDA approved for deep brain stimulation. So deep brain stimulation of the ventral capsule, ventral striatum is used for the treatment of refractory obsessive compulsive disorder. So I have to find in my institution who the psychiatrist is who has expertise in OCD. I also have to find out if that person is willing to consider surgical treatments for OCD. And given the checkered past of psychosurgery, that's not necessarily a given. And if you're dealing with somebody who trained a decade before you did, finished their training a decade before you did, whether that's the movement disorders or epilepsy or psychiatry, they may not be willing at first blush to give you patients. It may not be in their realm of experience, and that can be very disconcerting. Neuropsychology. My neuropsychology colleagues are critical because they're the ones who tell me don't operate on this patient. You shouldn't be touching this patient. You'll make them worse. So for instance, I have a patient with Parkinson's disease. I'm considering this patient's being considered for deep brain stimulation surgery. The neurologists are keen to go ahead. You stop at that point, you send the patient to neuropsychology for formal neuropsychological testing and figure out whether or not that patient meets criteria for early dementia, for mild cognitive impairment heading towards dementia. And the reason is obvious. I mean, I start stimulating the subthalamic nucleus, I make that patient worse. I take a patient who's compensated but has tremor, rigidity, and bradykinesia, and I make them unable to care for themselves. So neuropsychology is absolutely critical for my care of the patient. Remember that this is collaborative. What we do, whether it's spine surgery or vascular surgery or stereotactic and functional, is very heavily dependent upon the teams, the quality of the teams that we build. And those teams keep our patients and keep us out of trouble. The neuropsychologists also do the WADA testing for me to determine which side of the brain language is located on. So that's very important for my epilepsy practice. One of the things that can stop me dead in the water from building an epilepsy program is if the neuropsychologists and the neurointerventionalists can't get together and work out how to do WADA testing. Okay, because I need to know that I'm taking the patient to the operating room for a resection that's not going to jeopardize their language. Or I need to know that I need to keep the patient awake for their epilepsy surgery to do awake intraoperative mapping of their language region. And so the neuropsychologists help with all of that. Physical medicine and rehabilitation. These are the patients in our institution who deal with chronic pain and deal with spasticity and become a referral source for baclofen pumps, pain procedures of various types. Now, anesthesia in our institution also has in the past seen chronic pain, but currently not seeing chronic pain. And these sorts of political this sort of political landscape of your particular institution affect your referral networks, and you need to be aware of those. Neuroradiology, very important for anything that we do in neurosurgery. These are the people who will say yes or no to postoperative imaging of implanted patients, and that labeling is changing. When I first arrived at the University of Colorado to help with the stereotactic and functional programs, we were not allowed to get postoperative imaging on any of our implanted DBS patients. And it wasn't that it was off-label. We're allowed to do it by labeling, by FDA labeling, but the issue was more a lack of knowledge, a lack of understanding. So one of your roles as a physician building a program is to educate people. And to do that, you have to know what the issues are yourself. Now, that labeling is changing, and in the not too distant future, we'll be able to get postoperative MRI imaging, body imaging of a fully implanted DBS device. But right now it's considered off-label. But that again will be a battle in the future when that labeling changes, because people are, I am resistant to change, other people are resistant to change as well. Change is scary. So this is a sort of diagram that you can start to construct for your programmatic development. And it's important to be able to not just identify the divisions or the departments that will help you build your practice, but it's important to identify the key people. Because if you can identify the key people, you can find out what's missing. And that suggests recruitments, it suggests collaborations outside of your institution that can help you solve gaps here. Medicine, as I said, is dynamic. This is a list of indications on the left column, targets in the brain that we approach, and what the FDA approval status is on the right side. And so these are all FDA-approved indications for implantation of deep brain stimulators. So tremor was approved the earliest. Thalamic stimulation for tremor happened in 1997, approved by the FDA in 1997. Parkinson's disease in 2002, which is actually not that long ago when you think about it. Palatal stimulation for dystonia under a humanitarian device exemption became approved by the FDA in 2003, and OCD in 2009. The reason I put this up here is not because there's going to be a quiz on the dates that the FDA approved these indications for deep brain stimulation, but because it's completely dynamic. So right now, unless I am operating under the confines of an investigational device exemption, I cannot treat depression. So I can do it as a research study. I can't do it and have insurance cover it. Tourette syndrome, same thing. Epilepsy, the same thing. But epilepsy is in its final stages, we hope, of approval from the FDA. And that will be a complete game changer. So instead of seeing just the epilepsy patients who are eligible for surgical resection, we will all start seeing epilepsy patients who have multifocal epilepsy, epilepsy that's not amenable to surgical resection. So that opens up a whole new group of people referred to our practices for surgical treatment. Depression, if depression comes through, and there is very, very good evidence, preclinical evidence and human data to support DBS for depression, if that comes through, that will completely change what our clinics look like. And our referral patterns as well, I should point out. So how do you engage your colleagues? Because as I said, we do this in a collaborative setting. We don't do this by ourselves. We don't do it well by ourselves. And so you have to speak to people's enlightened self-interest. You have to approach your colleagues, the neurologists, the anesthesiologists, the PM&R, the physical medicine and rehabilitation doctors, the psychiatrists, and say, I can help your patients. I have something for you. You hate chronic pain, failed back syndrome. You don't like to treat that. I can treat that. I have something for those patients. And I will send those patients back to you, so you don't have to worry about losing those patients as a potential revenue source. But I'll make them better than they are right now. I'll make them less of a problem for you. And we will build this program together and we'll co-lead it. And with those three statements, you've addressed most of the obstacles that you run into when you're trying to build a program that depends upon other people. You have to also be able to address people's drivers, their motivations. You have to know your own motivations as well. What are you in it for? And so, is it clinical service? Well, it should be. That's why there are much easier ways to make a living than neurosurgery. Is it academic advancement? And if you're in an academic environment, this is a component of what you have to think about. So by academic advancement, is there a paper that can potentially rise out of this collaboration? Is there a grant that can be submitted out of this collaboration that leads to something greater? Revenue is always an issue. You have to be considerate of your own revenue streams because you can't help people if you can't pay the bills. But you also have to be thinking about other people's revenues. So, for instance, deep brain stimulation. If I approach my neurologist and say, I can solve that tremor, just give the patient to me, that's going to be a lot less successful than if I approach my neurologist and say, I can help that patient's tremor, and you can bill for the intraoperative microelectrode recording. I can't. It's bundled into even though I do it myself. I was trained as a graduate student to do electrophysiology, neuronal electrophysiology, but the neurologist can bill for it, and they can bill better for that intraoperative microelectrode recording than they can for seeing the patient in the clinic. And the neurologist can bill for programming once the device is implanted. And again, that bills out much better than the E&M code that the neurologist gets for just seeing a patient with Parkinson's disease, essential tremor, or dystonia. So that's much better received than just saying to a neurologist, I can solve that problem and I'm well trained and I know what to do. Let me handle this. So speaking to what their revenue streams are and how you can help them build that is really important, really powerful. And then finally, leadership aspirations. When you talk to your colleagues about co-leading a program, so being a director of a program carries a stipend from the hospital. Something to be aware of. It's not a huge stipend. It's on the order of, depending on your institution, $25,000 to $60,000. But that's an important thing, because that means $25,000 to $60,000 that you don't have to get in the clinic or the operating room. That comes into your department as revenue. So neurologists are very, very aware, keenly aware of that. Psychiatrists are even more aware of that because they need these monies. They need these revenue sources because they're not doing procedures necessarily. So being aware of those sorts of things within your local environment is very critical. So I talked about organizational charts. So knowing how LSU interfaces with your hospital, which is called University Health. Some other people were using another name for it. Willis Knight. What's Willis Knight?
The private sector.
Okay. All right. So knowing how that looks, what is the interaction between the School of Medicine, the hospital system, the faculty practice if you have one, or if you're in private practice, how your hospital system interacts with the private groups, how you interact with those private groups, knowing the leadership structures within those groups is really critical. And it's critical because these are the people you need to have as your allies to build a program. It's also critical because these are the people who can totally sabotage you. So you need to know who these people are. They need to know who you are. So the dean is critical, knowing who the dean is. And don't think that as an assistant professor or an associate professor, you're so low level that the dean isn't interested in what you do. As a neurosurgeon, you are a member of the largest revenue stream on campus. And that's just the way it is. And so knowing the dean, making that appointment to just say, hi, I'm boss, I'm one of your faculty, and this is what I do, and I'd like to help you take care of business, is a really important step. Meeting the CEO of the hospital, the service line director for the clinical neurosciences, the director of the operating room who can make your life better or harder, who the head of the capital equipment group is for your institution, and how that whole process works is really important. So take epilepsy as an example. Laser ablation hippocampectomies have just come in. In the past year, we've gotten FDA approval. It's an amazing technique for those of us who grew up whacking out people's temporal lobes along with the hippocampus. Being able to slide a laser catheter into the hippocampus, inch it forward slowly out of position, and ablate the hippocampus and send the patient home the next day is really extraordinary. But the laser ablation system is not cheap, as you can imagine. And so figuring out how to talk to the person who directs the acquisitions of novel technologies is really important. And so you have to be able to make a strong case for the fact that this is, although it's an initial expenditure of cash, it's a tremendous investment, not just in you personally and your patients, but in the entire healthcare system that you work for, because it's a marketing tool. And they know that, they get that. So all of these things that we do to take care of patients, or we do because we're intellectually curious, these are marketing edges for your hospital, your hospital CEO and the people working under that individual. They distinguish us from other institutions in our environment. Identifying who the head of the faculty practice group is can pay big dividends down the line. Figuring out, again, as I said, how the faculty practice group interacts with the hospital, interacts with the School of Medicine, very critical for your success, your ability to build a program, your ability to achieve your objectives. And again, knowing what your goals are, knowing what motivates you, where you want to be 5 years down the road, very important to stay on track. being able to align what your goals are for your programmatic development and your personal growth with the stated priorities of the hospital system and the School of Medicine are really critical, because that opens up much larger resources than you have access to, one patient at a time, one donor at a time, one grant at a time. How do you use resources to get the word out about what you're doing? Before you ever take that first job, you negotiate for a marketing budget as part of the process. And so hospitals are not at all surprised by requests of $75,000 a year for 3 years. $75,000 a year for 3 years buys you a lot of print, airwave, and television exposure. You have to be smart about it. You have to think about how you're going to spend those dollars and what makes sense in your market and the patients you're trying to reach. But it's a very successful way to get the word out. Internal advertising should be free to you in your own institution. They should not be charging you for that. But it's a good way to, if you think about how many people are employed by LSU in Shreveport, it's a good way to get the word out in a network that you already own. Signing up to speak to patient support groups. So for me, this is the American Parkinson's Disease Association, the local support group for them. It's the Epilepsy Foundation of Colorado. And these groups control huge numbers, have tremendous audiences at their disposal. And these are marketing opportunities. These are opportunities to tell people about your good work. Industry partners, absolutely critical. I have shamelessly used Medtronic to build practices for me in Atlanta when I was at Emory, in Minnesota when I was at the University of Minnesota, and now in Denver at the University of Colorado. And Medtronic gets me into the referring neurologist's office where ordinarily the door would be shut. They get me into those offices. They help me support large patient get-togethers to talk to potential patients and their spouses or their family members about what it is we can offer. These are all phenomenal ways to raise awareness in your area, in your network, about what it is that you do. This directly translates into increasing your volume for deep brain stimulation surgery, for epilepsy surgery, for pain surgery for pain, etc. So these are incredibly important. Finally, research. So why do we care about this? Everybody talks about it. Is it really important, or just a distraction and something that cuts into your RVUs and your bottom line? Well, it's more obvious in an academic neurosurgery department like this because we have this tripartite mission. So people think about the stool, the three-legged stool, which traditionally has been cutting-edge healthcare, education and training of the next generation of practitioners, and research. And people throw in service as well. We have a service role. But what does that really mean when you think about it? So this is taken from the University of Colorado School of Medicine mission statement, mission and vision statement. And one of our goals is research, through the development of knowledge in basic and clinical sciences, health policy, and health education. It sounds very noble, but what does that really mean? As I said before, there is a personal satisfaction element to this. And so you can help one patient in the operating room at a time, or you can try to, it's an aspirational goal, push forward what we can do for humanity. And that's very rewarding. That's very rewarding, and particularly when you think about why you went into medicine in the first place. But there's also a revenue aspect to this. And so, as I said before, if you can show that you're aligned with the mission of the School of Medicine, aligned with the mission of your hospital system, then pushing forward your own research agenda is actually a good thing for everyone. And it helps distinguish your environment, your community practice, your academic center from the competition. That brings in more patients. So the fact that I have funding from the National Science Foundation to look at intraoperative human electrophysiology is something that we advertise because it brings patients in the door. Because as a patient, I worry about parking and I want to know that my neurosurgeon wears a fancy suit and all of that kind of stuff. But I'm more interested in making certain that my physician is cutting edge. And to me, that means, is that person actively involved in research? Are they doing industry trials? Do they have funding from the government to do this? And patients are reasonably sophisticated. I mean, obviously it depends on where you're working, but there are patients that would surprise you in terms of what they know about you from internet accessible sources. This is our mission statement, and most departments now have something like this, and it emphasizes all of these things: clinical care, education, research, and service. How do we measure a department's academic standing? So you all went through a match at some point or other. You went through the interview process, looked at a variety of different places. Did you just throw a dart at a map of the United States? No. I mean, there are metrics that can be used to assess the quality of a training program, of an academic department. And these include the match results, the written board scores, the oral board pass rate, publications, national presentations on the part of the faculty and the residents, job placement on the part of the graduates, program accreditation, whether or not you're struggling with that or you're getting a pass. And then there are metrics of the faculty. There's clinical revenue. I mean, are we paying the bills, number one? Number two, are we a profitable center on campus? You know, what's the media profile of the faculty? What level of research funding, the publications, et cetera. Society leadership, and I've listed some of the societies down below that my colleagues and I belong to or are leadership in. And so that includes the AANS, the CNS, you know, Women in Neurosurgery, NAS, Stereotactic and Functional Neurosurgery, et cetera. It's a colossal headache. You know, Anil can probably tell you this better than I can. Why bother with the bazillions of emails in addition to all the other emails you get now coming from the staff of the AANS or the staff of the CNS to address this thing or that thing? Well, the reason to do it is because these are advocacy groups. Each one of these is an advocacy group, and they advocate for us. They advocate for American neurosurgeons, they advocate for our subspecialty interests, they advocate for our patients. And so they help us take better care of the patients we're trying to help. That's number one. Number two, they look out for our interests nationally. That's really important. And if you don't have a good sense of, say, what the Washington Committee does for us, it's time to look into that. But my point is not to say, you know, you need to pay your dues or anything like that. My point is to say that there are good reasons to belong to these organizations and to seek out leadership positions in them. And the leadership positions in these organizations, again, regardless of whether you're in a large community-based group, private group, or you're in academics, is that it elevates your status, your visibility nationally, regionally, locally. Okay, these are all things to crow about. And by elevating your visibility, you're then eligible for more resources than you would be. You're eligible for recruiting better residents, better faculty, better partners, et cetera. So be aware, keep your eye on the national scene. There are other metrics. There's the U.S. News and World Report. Every hospital I ever worked in likes to splash this, make a big banner, say where they are, how they've moved up in the ranks. I don't know who really takes this stuff seriously, but hospital administrators definitely do. Obviously, one way to look at the stats. Now, there are also institutional metrics of how a department is doing. And so the dean is interested in our research. So at the University of Colorado, they look at sponsored research trends over the last 6 years. They look at salary and indirect cost recovery. And the reason they look at indirect costs, so when you get when I get a grant from the NIH, I get what are called the direct costs, which is how much I need to actually do the work. You know, salary support for a neuroscientist who's working with me on a particular aspect of the project, salary support for a biostatistician, you know, devices that I need to implant because they're off-label, an extra day in the hospital to do some monitoring, that sort of thing. Those are the direct costs of the research. The indirect costs are the negotiated amount with the NIH that my institution expects to be able to pay for the IRB, to be able to pay the dean's tax, to be able to keep the lights on, to be able to pay for the library, et cetera. All those things that are invisible to us from an RVU standpoint or from a revenue standpoint are coming out of the 52% negotiated indirect recovery from the NIH. And so these are things that's very important to the dean because it keeps his staff afloat and it allows him to fund things on campus that are otherwise unfunded. So Other institutional metrics of how a department is doing. Faculty hires and terminations. Like, are you hiring people, but there's a revolving door? People are leaving. People leaving suggests that there's some dissatisfaction, there's some internal problems. Deans look at that. Philanthropy. How successful is a department in terms of garnering philanthropy? What you have in reserves for a rainy day. Administrative infrastructure. Do you run lean as a department, or are you super fat in terms of clinic schedulers and OR schedulers and administrative assistants on the academic side, et cetera? So these are all incredibly important metrics for the dean and for an institution. This is a copy of something from the University of Minnesota Physicians, the faculty practice group at the University of Minnesota. And the print is way too small, but this is a comparison between different departments on various metrics of access. Like, how good is the access that my patients have to me in the clinic as a neurosurgeon, as a stereotactic and functional neurosurgeon. And when you get a red mark, that's bad. You get a call. You get a call from the director of the faculty practice at the University of Minnesota. So those are the different ways that people are assessed in terms of the success of their programmatic development. So you can look at clinical metrics, at the RVUs, at the money that you're bringing in. You can look at metrics that assess the quality of your residency, that assess the happiness of your faculty. And these are things that contribute to your success in a direct and an indirect way, the success of your ability to build programs. So where do you start from the standpoint of measuring the quality of your academic productivity? Because that's that's a little less straightforward than the RVUs. RVUs are easy. You can add it up on a sheet and determine how you're doing relative to benchmarks that are set nationally. How do you measure how you're doing academically? Well, everybody's favorite comes from this man, Jorge Hirsch, who was the first person to publish what's known as the H Index. And you all know that that's in some ways linked to your publications, right? And so what he was trying to do is say not just how many publications do I have in Ladies' Home Journal, it's what was the productivity plus the impact of those publications. And so this is admittedly an imperfect metric, but it's a good way, it's the best way we have really to get at the impact factor of our academic productivity. So there are limitations, admittedly, and if I were tomorrow to submit an article to Nature that was completely fabricated and people found out about it, that it was the biggest fraud of the century, my H-index would go up, okay? That's not the way you want your H-index to go up, but that would have a huge impact because people would be talking about it for decades, right? So, in essence, a scholar with an index of H has published H papers, each of which has been cited in other papers at least H times. That's the technical definition. But in essence, if you want to look at how meaningful it is for your department, you look at instead of what's called an H10 Index, which is the cumulative impact restricted to the last 10 years. So what have you done for me lately kind of thing. Now, Ponce, who was a Stereotactic and Functional Fellow at the University of Toronto, where I did my training, in 2010 published an H-index survey of all neurosurgery departments in the US and Canada. And I've never seen an update of it, but it was a fascinating sort of premise that you could look at neurosurgery the same way you looked at a basic science department or an immunology department and go through exactly that exercise. Now, the notion of the H10 index is that it correlates significantly with other critical measures. So whether or not your faculty have NIH funding, the degree of NIH funding, the academic degrees of the faculty, et cetera. So it's as I said, it's an imperfect metric, but it's a place to start. And so we all look at this. We all try and improve our publication numbers, but from the standpoint of quality publications. And this is, this is, as I said, it's an old listing. This is 2009. I don't have LSU on here, unfortunately. There's the University of Colorado. And we've started to do this. And so The interesting thing here is that it's not just a metric of success or lack of success, or performance, I should say. It's how you are doing in your own institution. And once you start looking at this and you start presenting these results in public fora, it's amazing how quickly the publications go up. So it's a way to change. It's like looking at RVUs in a monthly faculty meeting. When everybody knows the data and everybody's looking at the data and you're all being forced to recognize that how you do as a department is what is the difference between you sinking or swimming, then you start to change your behavior. You can modify behavior. And so it was sort of interesting to go through the annual publications for University of Colorado Department, which I did when I first arrived there two and a half years ago, roughly. There was kind of a steady but low publication rate from 2005 through 2008 that corresponded to some intense local political factors and turmoil within the department. And as the new chairman kind of hit his stride and the political problems were solved, the publications went up. This was data, incomplete data for 2015. There hasn't been any, I'm happy to report, no further political trauma. But it is fascinating that you can identify trends in people's happiness and satisfaction with their job that directly link to academic productivity. You can then generate heat maps of productivity by faculty member, and these are important because if you are in an academic position, the coin of the realm remains publications, first or last author, first or senior. Being stuck somewhere in the middle doesn't count for a promotion and tenure committee's determination of advancement. And you can start to change that. You can start to improve on that. So what do you do with that data? If everybody agrees that it's valuable, then you can begin to trend the data over time and you can begin to provide individual feedback. You can do this for residents, and we do this for our residents at the University of Colorado, and they don't thank us for it, but it has resulted in increased productivity among the residents. And that increased productivity directly correlates with job or fellowship potential. So, something to keep in mind. There are a variety of different resources that we have available to do this, as you all do as well. We have a grants and contracts person within our department who marshals things through from I'm thinking of submitting a grant in February to the actual submission to the Office of Grants and Contracts and then to the funding institution. We have a science writer. We have a clinical trials specialist who serves as an IRB and FDA and keep us out of the papers kind of person. We have a biostatistician who we talk to before we begin to write a paper, as we're beginning to think about a study, who helps with trial design and then helps with statistical analysis at the back end. And then we have a database guru who helps us with database formulation for new projects. And there have been some complicated multi-center trials for which he's been instrumental. So you have these same resources accessible to you, not necessarily within your own department, but in the larger campus, definitely. You have, there are offices that deal with technology transfer. There's national databases like the NIH Reporter. So if you're trying to pick a lab and you want to figure out the guy down the hall, how productive is he? Does he have funded, he talks a good game, but does he have funded research projects? NIH Reporter allows you to look up an individual in an institution or a region of the country for a particular subspecialty that you're interested, area of research that you're interested in, and find out who's funded and the level of their funding. It's a tremendous resource because people with funding tend to get funding. And so it's useful to align yourself with people who are already funded, have a track record of funding. And then there are ways to take the difficulty, the intimidation factor out of coming up with your own resident research project and make it kind of research by the numbers. Not to say that this takes the creativity and the novelty out of what you wind up doing, but when you have a clearly laid out algorithm of how to approach this, it can be quite useful. That's the NIH Reporter website, and what I put in here was Department of Neurology faculty who's NIH funded, and it pulled up all of the faculty within neurology who had R01 funding and what the level of funding was, and then you can click on those various links and figure out what their specific grant has to do with. So one of our faculty, the question was, does he have NIH funding? There I can pull up his R01 and specifically what it's about. There's more information about his R01 if I click on that link, as I said before. So why do we do research? You know, we want to move forward patient care and improve patient care. We want to attract patients to our clinics and to our operating rooms. We want to engage in research trials. We want to enhance the reputation of our group, attract the best and the brightest, whether it's colleagues or residents. If you're interested in personal advancement within an academic institution, tenure remains the coin of the realm, and these are all incredibly important. As a neurosurgeon who is also PI on an extramural grant, whether it's NSF or NIH or DOD, you are unique. You know, you can count on the fingers of two hands how many neurosurgeons are PIs on their own R01s. And then there's an economic incentive. So for those of you who have borrowed money to pay for medical school or medical and graduate school, there's an NIH loan repayment program which will reimburse you up to $35,000 a year for engaging in research. And they define that research relatively broadly. You don't have to have an R01 yourself to be engaged in research. So something to keep in mind. So it's not rocket science, but you have to know what your literature is in your particular area of interest. You have to know what the knowledge gaps are. It's helpful to review all of these things, and because that informs your research proposals, your IRB protocols. You begin to collect pilot data and submit publications, and as you're doing all that, you submit proposals for funding, and those proposals get shot down. And then you do it again, and they get shot down. But this time you actually get reviews back. And you use that to inform how you send out the next one, how you structure the next set of grant proposals. And I could paper my wall and the walls of my colleagues' offices with all of the rejected proposals I've submitted. But that's not the point, because sooner or later you actually get funded. So how do you do this successfully? I mean, I did basic science for my PhD. I cannot be a competitive basic scientist and be a neurosurgeon who is safe. You know, you wouldn't want to come to me as your surgeon if I was spending 90% of my time in the lab. And yet you're competing with people who are spending 90% of their time in the lab. So you have to align your research interests with your clinical subspecialty area. You have to invest the time in the training, and there are many ways to do this. You have to get protected time, but protected time isn't really protected time. You know, as a resident, that was probably the most protected time I ever had in my life. As a faculty member, even when I had a K award, my time was not protected, unless I counted weekends and, you know, after dinner. But I know that if I have a case in the operating room, I have to be there at 7:30 to start that case. And you have to approach your research day the same way. So if you have carved out a day of your week to do research, you have to show up on time at 7:30. And that's how you do it. That's truly how you protect your own time. You have to make the same commitment to this as you do to the clinical aspect of your life. As I said before, finding a well-funded person with a track record of funding on campus who can mentor you helps tremendously. Because study sections expect to see who you're working with. Define your goals, ultimately look for independent funding. I talked about the myth of protected time. You have to block out the time and stick to the schedule. And then you meet with your research mentor. There are many different grant mechanisms that you're eligible for, specifically as a neurosurgery resident, and then as a junior faculty member. Interestingly, you know, does going into private practice preclude you from doing funded research? No. I mean, I work with a colleague across town who's actually my competition in the DBS market in Denver. Very successful, high volume practice, very bright. I'm not sure where he started off at University of Washington in Seattle and then moved to Denver. And I reached out to him as in the context of a multi-center industry-funded trial to see if he would be interested in being involved. That has paid huge dividends for him and for me and for our patients. So you look for those sorts of synergies, and it helps you in many levels with programmatic development. This is a checklist that we created at the University of Colorado to help the residents who were somewhat intimidated by the research component of what they were supposed to do, because you get a schedule when you're on service of where you're going to be for the next 7 years. You know exactly where you're going to be, and that can change, and that causes some problems. But you have it's all mapped out for you. Mapping out the research aspect of what you're expected to do, I think, goes a long way towards creating success in this arena as well. Having CAST-approved fellowships in various different divisions, subspecialty areas, I think helps tremendously with programmatic development. So having a fellow in stereotactic and functional has been a godsend in terms of my academic productivity, clinical productivity, and visibility on campus. The same is true for our skull-based program and the neuro-ICU program. Attracting national courses. So we run a skull-based course annually at the University of Colorado. Brings in faculty from all over the country. It brings in industry from all over the country because they sponsor this. Same thing for stereotactic and functional. Next week, actually, we have our stereotactic and functional course, which is sponsored by those organizations, our society, AANS, and NRAF. Industry is heavily engaged, and it's a way of training residents, fellows, and fully fledged neurosurgeons who have been out practicing for 10 years who perhaps haven't done neuropace, who haven't implanted responsive neural stimulators for the treatment of epilepsy. So it's a great way to increase your visibility, build your program, stay engaged, and stay trained. As I said before, knowing your referral patterns on campus, identifying those critical new faculty hires that you need to do what you need to do well. So this is kind of a summary diagram of what we look at when we look at departmental national standing. We need to work on our clinical volume and subspecialization. We need to have a superb training program because it's part of the mission. We need to beef up the research in terms of publications and grants and national reputation. And then all of these things actually affect individual advancement. And these are reciprocal arrows because the better the individual faculty are doing, the higher the department's national standing. So that's kind of a summary of what I wanted to say about programmatic development, but I can't imagine that you guys don't have questions about some or all of what I've spoken about today. So I will open it up to questions.
I like the neurosurgery resident checklist. That was excellent. I want to get that.
Sure.
That's something I'm going to immediately.
It's very useful. I mean, I think that if you've gone through an MSTP training program or done a PhD before you've gotten to residency, it's much more straightforward how you sort of hit the decks running in terms of research career or an academic career. But if you've never had that exposure, there's nothing about medical school that teaches you how to carry a project through to fruition and identify a mentor, identify a project. There are many good projects. How do you find funding, that kind of thing. And so having it laid out as a plan, I think, can be very useful.
Hi.
Great talk. I wish I had listened to this before I was looking for jobs. So I would have negotiated with Dr. Nanda a lot of more things.
Marketing budget for $100,000.
Anyway, one of the things that our department is doing is we try to build up our epilepsy program, and we have had our first epilepsy conference last month for having had it for a while.
Congratulations.
Thank you. And I was just wondering whether you have any advice on how to interact with the neurologist from the surgeon point of view, and try to get them to trust us and bring the patient to the pipeline for the surgical work.
Right. So So as I said, I was at Emory, where there was a very large, very surgically focused epilepsy program, and that question never even occurred to me. Like, why wouldn't they shower you with patients and come to conference and, you know, do all of that stuff? Then I went to the University of Minnesota, which it was probably the first epilepsy program in the country, but the entire epilepsy neurology group had moved off campus because of a fight with the dean in the 1980s and established a very, very high-quality private epilepsy surgery program in the community right next to the University of Minnesota. And so when I was hired by the University of Minnesota, one of my jobs was to replace the retiring court epilepsy neurosurgeon for this private group, MINSEP, and continue to do what MINSEP wanted us to do. And that all worked well until I got NIH funding for an epilepsy project. And this private group refused to participate because they didn't want to have to potentially open their books to the NIH or governmental regulators in that fashion. So at that point, I started to wonder why I was engaging with this private group. So I was in the situation of having to repatriate an epilepsy neurology program, essentially. The epilepsy neurologists we had on campus were not interested in surgery. I mean, they weren't opposed to it. They just didn't, you know, it hadn't been part of their training, and they didn't know how to provide patients. And it came down to having to actually build a program. So recruiting, you know, you try and work with what you can, and if you can't do that, you're a human and you can modify your environment. And so at that point, presenting to the dean how much revenue was going out of our system into this private group led to 2 critical faculty recruitments on campus in epilepsy neurology, and people who, you know, we were able to vet who were interested in helping to build an epilepsy program. So, you know, it's a question of identifying the resources that you have, and if you can't work with those, then figuring out a way to bring it in. And one of the things that we were able to do very quickly was to obtain NAEC level 4 standing, so National American Epilepsy Comprehensive Program standing. So level 4 is the highest, and level 4 is what you have when you have an epilepsy monitoring unit where you're implanting grids and doing mapping, et cetera. And these things help, again, very quickly, because we had the research engine of the University of Minnesota behind us, the way you have the research engine of LSU's medical campus behind you, you're able to distinguish yourself from the community-based epilepsy programs, if there are people in your community doing epilepsy. Does that help?
Yeah, certainly.
Okay.
I think one thing I find is a little difficult for us to do is, for example, if I see a patient with a cavernoma, what I think immediately is resection. But now, in order to build up this program, I think those patients probably should be brought to the epilepsy conference, do the video EEG monitoring, and then, you know, get the neuropsych testing and all that. So is this a tendency for us to say, okay, slow down, get everybody on board? Probably this is safer for the patients.
Yeah, I know completely what you're saying. I mean, there's a flashing light pointing to the cavernoma. Why can't I just take it out? Because it's lesional epilepsy. But part of building that collaborative approach, that comprehensive group that sits down and discusses patients, is having patients with your epilepsy team and having them agree with your decision. Because remember, it's, you know, they're not there just to support your independent decision about who needs surgery and who doesn't. They're there to help you build the program. And so having a little patience with them about that flashing light kind of situation is really going to pay big dividends. So. Yeah, no, everybody gets the same time, and as I said, you know, one of the things that leads to huge conflict, did to me as a resident, still does as a faculty, is when the schedule changes. So obviously schedules change. People get hurt, people go on maternity leave, people quit, whatever. And so research, although, you know, everybody should be getting a year of research in their PGY5 year, there's, you know, obviously some flux to that. And so, and then people decide to do what they want to do. You know, they're with residencies going to 7 years, people now want to do enfolded fellowships rather than extend their indentured servitude another year or two. Go figure. So people do different things with that year, that PGY 5-year, but everybody gets the same amount of time. It's a good way to create tremendous conflict within your program if you start showering, longer time for some people than others.
And I guess just one more comment about collaborating. I think it's important, you mentioned the money up front for DBS programming, and I think this will extend pain and spasticity, which is probably more relevant to some of our guys going into spine. Make sure you know what your colleagues want, because I have 2 neurologists, one older and one younger, and the older one actually did not want the money for programming. He was like, if you can't program, I'm not working with you, because it wasn't money that was important to him, it was time.
Exactly.
And he didn't want to spend the time because he's very quick with his patients. So I think, and same with pain and spasticity, you might think, well, they want to they want to work with PT, they want to fill the pump. Make sure that you actually assess what the person, it might be that they are an office rat and they're like, I like my 50 people a day, I don't like, you need to have a nurse that's like refilling this or checking this or working with PT to do these spasticity scales. So sometimes I think we assume that people might want some things and time is actually more important to them. They don't want to spend a lot of time on assessment or for DBS programming. And then our younger neurologist was the opposite, but was saying, well, I don't know how to do this. Can you come in with me? And that is definitely a monetary hit up front. I would spend an hour with current patient and I bill for none of it basically, but I think that eventually was worth it if you have to work with somebody right up front who does want to capture that income. You can send them to a course. Saying, like I said, it extends to the dealing with the pumps and things. You can send somebody to a course, but if you have a skill that you know about and you're trying to transfer, you will need to take a little bit of a hit up front to teach someone new. And just count your blessings that there's just somebody new that wants to work with you, even if they don't have the background. And eventually now she's independent, but I do think that first 6 months, that was just a sacrifice to teach a new skill that had to be made. That, important to sort out what they want, because some it's money, but others it's actually time.
Right. No, getting at their drivers, getting at your drivers is really the best investment up front that you will make. Figure out how it will work.
So on behalf of our department, a little plaque in commemoration of your visit to us. Thank you so much.
Thanks very much.